And here we go. Welcome everybody to The Big Idea. I'm Dr. Jeffrey Hanna, and we've got another case review for you today. This one is on a woman who has basically been experiencing daily headaches or near daily cluster headaches for well over 20 years. And we're going to have a look at a few of the things that are showing up on her MRI scans and also the additional DAX scans that we did to see if we might be able to figure out what exactly is going on and what type of solution can we offer for her. Let's have a look. Now, as we're starting, and it's so often the case for many people, I see no signs of discrete pathology on any of her scans. But as is often the case, it's the combination of a whole bunch of little functional disrelationships. That's what seems to paint the bigger picture, and we have to take those little things into account so we can better understand what is actually going on. Otherwise, so many people just slip through the cracks. So the first thing that we see on her MRIs here, and I've gone ahead and I've put a couple of little markers here for you, is a phenomenon that's known as cerebellar crowding. So in brief, the cerebellum, it's the balance coordination hub at the very back of the skull. It's where your skull meets the upper part of your neck. And as oftentimes we see in people when they experience chronic headaches, migraines, blurry vision, balance issues, brain fog, different kinds of things like that, what I'm seeing here is that the cerebellum is actually descending very, very marginally into the opening at the base of the skull. And we've done plenty of videos on this channel discussing what cerebellar crowding is versus Chiari malformation. Now, if you've never checked into any of these videos, let me describe briefly what this is. A Chiari malformation is where the cerebellum actually descends down into the spinal canal by bare minimum 5 millimeters. And as you can appreciate, what that does is if you've got extra tissue that's essentially herniating out of the base of the skull, that can start to put direct mechanical pressure on the surrounding nerves. It can disrupt fluid, lots of different things like that. But huge number of people, they have an MRI and they say, nope, there's no Chiari malformation, so case closed, right? Not necessarily. Number one, what the emergent research is showing, that it is not the length of the descent or the herniation essentially that matters the most. It is the width. And if it starts to obstruct fluid flow, that is what the far more significant factor is. And that can happen even if a person does not have that true blue 5 millimeter descent. This is why I'm not calling this a Chiari, I'm calling this cerebellar crowding. Because as you see, this dark little bit of tissue should actually be sitting all the way up here, kind of where the tips of the arrows would be, but it's all the way down here. And if we come to this slice where we're looking at that opening, what we're seeing here, this dark gray shadow right here, this is the spinal cord itself. These extra dark little dots that you see right here, those are going to be the pair of vertebral arteries which are supplying blood up to the medulla, up to the cerebellum itself. And what I'm saying is that this entire space through here should be bright white. But what you see is that it's all kinds of shades of gray. That is because the cerebellum has descended into that canal just a little bit. Whatever size shoe you wear, could you fit into 1/2 size smaller? The truth is, yes, you could, but it would feel tight. That's what happens when we've got this cerebellar crowding phenomenon going on. It starts to create pressure issues in that area, and it can be a choke point so that the cerebrospinal fluid, that bright white stuff that's going to be supplying energy, oxygen, nutrients, ions for the brain, it's not able to flow properly. As a consequence, you can start to have the buildup of pressure, and like we said, you can start getting daily headaches, daily migraines, daily dizziness. A hallmark sign of this is that it feels worse if you lean your head back or if you're doing a whole bunch of exercise. Just, I get a pounding headache every single time after I do that. So Not a Chiari, but we're seeing the same type of effect here where something's affecting the way that that fluid is flowing. Now, in addition to that, what I am seeing here is I'm seeing what could be an anatomical variant, or could be sign that something is also impeding circulation back from the brain itself. So you might notice that we've got a pair of circles over here on the right side. This smaller one here, this is the internal carotid artery, so supplying blood up to the forebrain. And then this big oval that you see right here, this is the internal jugular vein that's going to be the primary drainage pathway from blood back down from the head. Now, if we come over on to the other side, what do we see? We see that same carotid artery right here, no problem, but where's the internal jugular vein? Maybe you can make a case for this, but one way or another, it's much, much smaller. And this can be one of two things. Commonly, when this is read by medical radiologists, and it is truly the case, that our vessel diameter in many, many people is not going to be the same. One side is going to be really big, and the other side is going to be very narrow. But in the same breath, if we're going to look down just a little bit, as I'm going to show you here in a moment, it's not always just an anatomical variant. This could reflect where there is a mechanical constriction of that vein, because veins are loose and floppy, and the consequence of that is that can produce a backflow of fluid and pressure, goes up into the head, and again can make a person have persistent headaches. And here's the very reason why I am less inclined to call this an anatomical variation, because when we're looking at her MR slices here from a side perspective now, so that we're able to see the internal jugular veins from the side. So we've got the right one is going to be over here and the left one's going to be over here. You'll notice that the course of the right one, that tube, that black shadow, is pretty doggone wide all the way through. Maybe a little bit narrower through here, but that's not uncommon. That's quite very normal. However, when you're looking at it on the left side, you can see this constriction point right here. And I will also point out, you might notice this little whitish knobbly thing with all of these structures coming off of it. This here is the tip of the C1 vertebra transverse process. Let me grab you a little model here so that we can illustrate how and why that this is the case. So this would be the vertebra. So here's the front side. I'll kind of turn it like that. Actually, I'll do it like this. So front side, top of the vertebra. So the transverse process, the tip, that's what this little structure is right here. So the internal jugular vein sits right here. Therefore, there can be cases where what happens is if we've had some type of neck injury, whiplash injury, concussion, so head injury, that disrupts the normal relationship, the normal plane of motion for this vertebra, its center of gravity can cause it to go forward. And as that happens, because you're going to have other soft tissue structures in the back of the jaw sitting right here, that can essentially produce a mechanical constriction of that area right there. And then what we end up seeing is this phenomenon where the tube that's going to be draining blood back down from the head doesn't have near as much patency. It's much narrower. And as a result, as we said, you can start to have the accumulation of fluid back up onto the inside. So not only are we seeing a disruption of the cerebrospinal fluid inside of the head, we're also seeing a potential constriction point for that fluid to come back down. Now, I'm also seeing something that is considered to be an anatomical variation, but honestly, we're not 100% sure about this, because yes, this can be a person simply put normal anatomy, or it can be a sign that there's some type of mechanical tension that is affecting the way that the blood vessels into the brain themselves are transmitting along their normal course. It's a phenomenon that's known as a Dolichoectasia. Big fancy word, but what it simply means is a twisting or a tortuosity of the arteries into the brain. So These here are the top down. Well, this one here is a bottom up projection. So we're looking at just a little bit higher up into the brain. And then this here is going to be a front on projection. If you are looking at normal anatomy textbooks of vessels, which I don't expect you to do that, most of these vessels are shown to be symmetrical. So what happens is you've got the two pairs of vertebral arteries that transmit through the neck, coalesce toward the front part of the medulla, and then become one midline artery, which is known as the basilar artery, which is supplying blood to all of those vital life centers. But what you're seeing here is you're seeing that there is a notable asymmetry. So normal positioning here on the right, but then the left vessel, it's kind of torquing across the base of the head, or excuse me, base of the brainstem, and then ultimately coming back to midline. That's what we're seeing right here. And you don't see the artery in its full course profile, but on the right side, that guy would be coming up like this. This guy, it's crossing over to the other side before ultimately coming back to midline. And what do we see? This right here would be the medulla. And as you can see, as that artery on the left side is coming across, do you see this slight indent or flattening right through here? It means that the artery is sitting right up against the neural tissue, and arteries pulse just a little bit with every single breath, every single beat of our heart. And this oftentimes, because it's producing just a little thump like this can be a source of mechanical irritation that again can cause a person to experience headache, migraine. Sometimes we're going to see people are going to experience pulsatile tinnitus because of this phenomenon, so a persistent ringing in the ear, and or a person is going to be experiencing various forms of dysautonomia. And this could be either because something's affecting vagus nerve functions, so foggy head, digestive issues, feeling like passing out, or a person could be locked into a state that's known as a sympathetic dominance. That is where essentially all of the neurons are firing and a body is stuck in a perpetual fight or flight state. Now, would it be so vain or stupid of me to say, oh yes, so what we can do is we can do this magic little adjustment for the neck and it's going to be able to undo all of that stuff that's going on anatomically? No, that would be stupid. But what I'm saying here is that these are the factors and these are the cards that we have been dealt. This is what's going on with this person's brain. So we want to have a look then, is there some kind of mechanical issue that we can address that at least has a biological explanation? What can we do that's going to increase that overall functional space so that system might be able to work a little bit better? So here's what we found when we were doing our own assessment. So what we took were a series of digital articular x-rays. This one here, it's just a standard neutral lateral or side view where we're looking at the neck, nothing fancy right through here. But I'll point out a couple of things. And oftentimes people will say, it's like, well, wait a minute, I already had an MRI scan. Why do I need additional x-rays? Are they not inferior to MRI? And the answer is no. With MRI, we're able to see brain and soft tissue really, really good. But we don't typically see bony tissue near as clear unless you're dealing with a discrete pathology like a bone tumor or an infection or something like that that's affecting the soft tissues as well. In addition to that, MRIs are done lying down. As a result, you don't necessarily see the mechanical elements in terms of what the stress from gravity is doing to the spine. So this is where either X-ray, cone beam, any of those types of studies, that actually gives us that information. So two different modalities are showing us two very, very different things. So what do we see going on here for her? Number one is her neck is way too straight. This here, and also where I'm looking, I see little bits of wear and tear through here. Actually, not too much wear and tear through her neck at all. So this is a relatively good thing. But the big thing is that her head is sticking way too far forward like this. Normal skull and head with all the stuff on the inside, it's going to weigh about 8 to 10 pounds. The normal position of the ear should be right over the tip of the shoulder. Every inch that it goes forward, that's going to essentially double the amount of stress and strain on all of the neck tissues. That includes the muscles, the joints, and also some of the free nerves that come out of the back of the neck and go up to the head. So I look at this, if she said, nope, I don't have any neck pain, I don't have headaches, I don't have migraines, that would be what would actually surprise me the very most. So we do see that there's some evidence of abnormal mechanical loading going on in her neck. In addition to that, I was seeing where there's a little bit of a forward slip of the C4 vertebra right through here relative to the C5. Now, I wanted to check this in particular because we did an assessment for hypermobility for her. She said that, yeah, I noticed that some of my joints are a little bit extra flexible. And we did a series of tests that you're looking for things like Ehlers-Danlos syndrome, which is a genetic susceptibility where ligaments, simply put, are more lax. People are more susceptible to aches, pains, problems, different things like that. And I measured the total amount of forward slip here. In order for you to be dealing with a true instability, you're looking at about a 3.5 millimeter total deflection. I don't have them here, but we also did some additional views where we were looking at that. It's like, okay, nope. This one here, this segment, it's not unstable, but it still is under a little bit more stress and tension than it certainly should be. The other thing that we did was we did this little measurement right through here. This is what's known as a clivo-axial angle. In brief, it's the relationship between the base of the skull, where the medulla is going to rest, and the upper part of the neck. The normal range should be about 150 to 165 degrees. And this is either a reflection of a person's normal anatomy, or this is a reflection of past trauma. And in her particular case, it's not quite, but you can see that's darn near a straight vertical line, near 180 degrees. When you see that line go to that limit, it suggests that there is some type of ligament laxity. It doesn't mean that the person necessarily is going to have symptoms. It doesn't necessarily mean that they need injections, and it doesn't mean that, whoa, you can never do an upper cervical specific adjustment for this person, but it does mean that something is having to move a little bit more than it ideally should. There's been some type of past physical injury here, either a discrete injury, such as car accident, sports injury, nasty fall, you get the idea like that, or it can also be repetitive stress injury, always having the head going down and up, working at a cashier, working on a computer, having your head glued into your phone 24/7. All of these things added up over months, years, decades can start to produce a little bit of extra stretching right through there. Nevertheless, pointing, yeah, something's not quite very happy, something's not quite right in that area. And then what we ultimately found when we were doing her articular analysis, these are oblique views that we did so that we can see how are the individual joints in her neck actually aligned. As a reflection, are they moving, are they functioning the right way? And any joint in your body, I don't care if it's in your neck, your low back, or your little toe, its neutral or centric position is where the two margins should line up like this. When you see disrelationships like that, that means something ain't moving the right way. So it's a little bit fuzzy, but I've gone ahead and put in a couple of arrows here that what we're looking at first, this would be the joint that's at the base of the skull on the right. And here is that C1 vertebra, and we see that, yep, those guys are straight across from each other. Nothing abnormal, nothing weird to see here. However, when we're looking over to the left side, what we're seeing is that there's a disrelationship. This is not an unstable condition. I want to emphasize that again because there are oftentimes phenomenon where we're looking at C1 and C2, a condition that's known as a craniocervical or an atlantoaxial instability. This is not the same thing. This is also not dislocation of occiput relative to C1. In order to have something like that, you'd be seeing a disrelationship in excess of 3 millimeters. What I'm seeing here is one that's about 1.5 millimeters. Nevertheless, that is quite more than enough if the vertebra has essentially misaligned from its normal or centric position. That can be very well the source of a lot of this tension. So I come back to this picture over here. Again, we already had this information, but now we've got extra information to support, well, what could be creating this type of mechanical compression. What did we see when we were looking on her x-rays? We were seeing that there was disrelationship occurring on the left side of C1 right here relative to the base of the skull. That means that the vertebra has misaligned forward like this. And what did we say about those structures located right there? That's what we're seeing the issue is. So, as we're going to be recommending a course of care here, what do we need to do? Well, we need to be able to give and restore a little bit more movement, allowing this guy to come backward a little bit. In principle, and usually we don't need to redo MRI scans or anything like that if a person's feeling a lot better, but you can appreciate if we're able to restore a little bit more functional space, allowing that guy to glide backward and getting the head back over the tip of the shoulders here, that can help to restore that normal circulation, that normal flow, and we're expecting that she's going to be feeling better for that. And just as a brief little aside there, I got curious a few years ago and did some in-house research looking at people's different misalignment patterns in the upper part of the neck. What I found was that 80% of the time, if there was a misalignment with that top vertebra, it actually misaligned forward. But think about that for a sec. What do the vast majority of PT, massage, chiropractic treatments focus on? They're focusing on working on the muscles or working on the joints from back to front. And as a result, people may be having the right kind of work done in the right area, but not necessarily to the direction that they need so that they're actually getting long-term stability and a long-term restoration of function. So that's what we're going to be working on right here. And that's really important for a lot of people. If you've been out there, you felt like you've tried all of the different kinds of treatments, the different kinds of therapies, and it helps, but it only helps for like a day or two. What it suggests is that, number one, you could be doing the right thing, but in the wrong order, and there's something that's holding you back. Or that working in the right area, but you just need to have a little bit of a modification in terms of what that treatment protocol is, and that's going to help you get the breakthrough that you are looking for. So, hope you guys enjoyed this particular video. If you did, please do click the like and subscribe button. That way it helps other people find this information when they're trying to find answers for what's going on. And if you've got that friend or family member who's been dealing with some of these kinds of symptoms, those long-standing headaches or migraines, please share this video with them. I hope that it helps. If you want more, you can check out some of the other videos on my channel here, and you can also check out our website, which is clearchirospokane.com, if you want to get in touch with us and we can help in any way. Thanks for watching again. This is Dr. Jeffrey Hanna at Clear Chiropractic. Get well, live well, stay well.